This is 102.3 WHIVLP-FM in New Orleans. We are Radio Null HIV with programming. That's right, programming dedicated to rights and social justice. .org. We honor independent voices. We are not a radio station with a mission. No, we are a mission with a radio station. Welcome to NoiseFilter, the weekly hour-long your friend and Griggs and I sit and talk about all things COVID up to the week. Sitting across the digital divide is my friend and yours, and that's Doc Griggs. Say hello, Doc Griggs. I know that Doc Griggs is here. His we are unable to hear him. We'll try again. Doc, are you there? I think Doc Griggs may be on mute. Let me see.
I was on mute, but I am here. I'm going to a more quiet environment so you can hear me. Can you hear me now?
Okay, yeah, we can hear you loud and clear. Okay, bueno. How's it going, Doc Griggs?
Good. That unexpected company dropped in town. So I will. I'm in my car, so we can do our show as peacefully and expeditiously as we can.
Awesome. All right. Were you at home and you just left your home and just went into your car?
I did.
Awesome. All right. Well, Doc Griggs, I know that over the course of the last week or so, you've probably done a couple. Do you want to talk to us a bit about what people on the news are looking for?
Now, everyone's looking for. Everyone's just looking forward to Mardi Gras and wondering what precautions they should take and what to expect potentially afterwards. That's it. Other than trying to follow as it maps itself out the subvariant of Omicron 2B.
Right, and that we're going to talk about that BA2 or that 2B in just a moment. It is part of the rundown today for sure. As we are going to be a little bit more geared toward radio. So for our folks that are watching, this is going to be a little bit more radio heavy of just reading things as we're still don't have time to print stuff, but hopefully over the course of the next week we'll be able to do that. And again, thank you for all of our viewers that are watching live on YouTube right now. Please click and like this stream so other people can see us. As always, please feel free to us on the chat. We always love to answer your questions. So, Eric, you're saying over the course of the last couple of days, you've been talking to people and about Mardi Gras. Are there any Mardi Gras wisdom for people that are listening right now or viewing the show? What are some basic Mardi Gras wisdoms we can offer folks?
It's essentially the same that we've been saying this entire time. COVID is not going anywhere. It's not like it's a light switch. Everything that we've done to protect ourselves up to this point, we need to continue to do. If you feel sick, stay home. Avoid large crowds. If your bubble happens to meld into another bubble, find another bubble or find a place to be by yourself. Wear your mask. Get your vaccines. Get your vaccine, both shots. Get your booster. Of course, wash your hands because we never wanted you to stop doing that in the first place. But just use your common sense and be wise.
Yep, and those are all great points. I think on WBOK we offered some good wisdom as well. We do have a regular segment on another local radio station from about 11:30 to about 11:50 every week, Wednesday at 11:30 on WB AM, in which you and I kind of broke down what some of the Mardi Gras wisdom in terms of should be for protecting yourself. And the thing I think we always go back to the message we've had since the beginning, which is essentially outdoors is better than indoors, small crowds better than larger crowds, and mask. You know, that masking is so incredibly important. We continue to be passing on the message of masking. Certainly, you and I had talked about masking, especially over the weekend. I had gone to a few parades, made sure that it was in large groups of people, just groups of people, not even large. I remain double masked, and I'll be in a parade tomorrow night Rolling Elvi in Muses. I'll be double masked for that. And any of that, there's going to be groups of people around me, I will be masked. What is your parade going strategy, Eric?
My parade going strategy is typically to not go. If so, I would watch from afar. You always say what you're not going to do for Mardi Gras, and you get enticed to do other things with folks, and you just have to be strong in your principle to mask, double mask, or do things that would be most protective to yourself. So we'll see. I can always say what my plan is, but it gets thrown out the window. But none of my plans none of my plans don't include double masking with strange people, having rapid tests, and staying at home if I don't feel well.
Absolutely. Such advice, and important for us as well, because we have to remember one of the things that we're going to be talking about today is that we still are in a global pandemic. It does feel less, and we're going to show you some slides probably in about 40 minutes or so of where we're at before we go, do the rundown of the headlines of what's going on. But we are still in the global pandemic, and we can still get reinfected. And as we will always say, if you haven't been boosted, please get boosted. And now, Eric, as you know, I developed an order over the course of the pandemic this past year, and we're going in to get my 4th dose of the vaccine. And the reason why I'm doing that is largely because autoimmunity now serves as a not autoimmunity, but immunosuppression rather, which is autoimmunity, serves as a reason to get a 4th dose. So getting a 4th dose as well. This will be the first one I will not be getting live on TV, but if we want to arrange for that, we certainly can if you want to make that a talking point. But yes, I will be getting a 4th dose, largely due to my immunosuppressive status. Thankfully, in the scale of immunosuppression, mine is low in terms of immunosuppression, but still immunosuppressed, still nonetheless. So I will be reporting back at some point. My
Nice.
Any thoughts, Eric, or should we just jump into some of the news?
No, any thoughts you want? Just want to make it clear that it's not recommended if you do not have a diagnosed autoimmune, have not talked to your healthcare provider about your immune status. We don't want people going out and just randomly taking 4th doses. Make sure to talk to your healthcare provider to make sure that it's safe. It's the best thing for you.
Absolutely. It's super, super. And again, that 4th dose with autoimmune disorders, you can get anytime if you do have an autoimmune disorder. With that, let's just jump into a bunch of the news. Eric, I will be off screen kind of reading stuff, so let me know if you have questions or thoughts or whatever. But some of the headlines today is that Moderna COVID vaccines can be up to 8 weeks now. It says updated CDC guidance. The interval, as we know, between 1st and 2nd dose may now be as long as 8 weeks for certain people. So who are those people? Well, before that, let's remind ourselves that the COVID vaccine of the Pfizer and Moderna, you waited 4 weeks after Moderna and 3 weeks after Pfizer. But what we have seen are these small cases of myelitis that affect boys and men in their ages of 12 to 29. Those were at the highest risk. Now, fortunately, these are these risks are very small, and the actual disease process was very, very mild. But still, what they found was that if they extended the period of time between the doses of vaccine, what they found was that small risk of myocarditis would be negated. And now what they're saying is that an 8-week interval may be optimal for some people, and specifically for male to 39. So there we go. We have a new recommendation, Eric. Booster dose are also recommended about 5 months after the dose. And of course, for Johnson & Johnson after. So recommendation helping to quell or to deal with some of the myocarditis. Any thoughts on that? And I'm just, before you do, Eric, I just see here that there's a short in my microphone. Are you seeing as a short at all, Eric? Or?
No, I can hear you.
Okay, so
I can
sorry.
hear you.
Thank you for the heads up.
What are they missing?
I'm gonna just, while Eric is answering, I'm gonna dismantle and plug everything back.
So my thought is that I think it's interesting. This is the first time myocarditis has been addressed with respect to a vaccine. The myocarditis is not unique to the COVID vaccine. It's not a unique condition at all. It's seen in younger boys, those of younger age, adolescents, and this is actually a good thing. The more time we have with this virus, which seems like it's going to be a while now, the more time we get, the more we're able to study it and understand how to live with it. People like using the term endemic. Bottom line is, it's not going anywhere, and you should try to make it such that neither are you. Doing everything you can to protect yourself.
Right.
As the virus, remember, the virus doesn't spread the virus, people do. And as long as it's given time to mutate and try to figure out how to stick around, we're going to hear about different variants. We'll hear about different traits, different characteristics. This becomes a long-term, lifelong relationship with
Eric,
our life lasting longer than the viruses, hopefully.
Yeah. Eric, what are your thoughts on the fact, how is this, as a health educator and a personal communicator and broadcaster like yourself, how is this perceived after 2 years? What appears to be new guidelines and what is not preceded by is something these will continually change. And now all of a sudden, what seemed to appear out of the new guidelines for young people and the interval of time between vaccinations. Now, you and I know that's just because they're constantly doing this and seeing what the best studies show. But how do you feel it's going to be perceived more prone to dismissing some of the guidelines, especially if they change pretty quickly?
Well, the first thing is that the whole purpose of the show, the name of the show is called NoiseFilter. What happens is there have been so many changes, so many guidelines without any contextual prefaces that, it's going to be heard as white noise. Okay, they didn't go in another guideline. They don't know what they're doing. But this is science, and that's how we learn what to do. The big problem throughout this pandemic is we had a lot of preprint and non-peer-reviewed studies. Before you get something published, especially before it's made into policy, prior to this, there were a lot of things that happen behind the scenes that you and I are very aware of when it comes to research. The peer review process is brutal, and you're super scrutinized. So as we move forward and there's more time, these preprint studies, a lot of preprint studies are going to go to the wayside. But the problem is they've already been embedded in the mind of the public. So it makes it appear as though you're unsure, or that you're not really confident in what you're saying, or even worse, you don't know what you're doing. So that's one of the things. But the big thing is that we're tired. A lot of people don't care at this point. They're just tired. It's COVID frustration. It's beyond cognitive dissonance now, because you lose faith in those that are giving it guidance, because every time you feel like you've mastered one aspect of protecting yourself and your family, it seems like something changes. And that's almost quotes from people that I've heard. It's not necessarily the case. It's a scientific process, but that's what you hear. So now your sound is out, sir. There's no sound. Not really sure, but we can see your mouth moving. If we had David Ross in here, we could do the Esma. There it is. It's almost, you're back.
Hello. Hello.
There he is.
I've been trying to take on the persona of Esmeralda's sister.
Right.
Anyway, hopefully this is well. So on to some science, like Eric was saying, how important science is. So he studied that finds something that's no surprise, something that we've talked about, but children's respiratory droplets and errors include understanding COVID-19 transmission. Children ages 8 to 10 put out a quarter of these particles as adults do when breathing, speaking, and singing. And I would imagine it's significantly less than that. But in a study in the Journal of Royal Society Interface, they researched 15 children ages of 8 to 10 and compared that between 15 adults, and they measured the number of emitted over time. Now, in particles and volume particles. Now, here's my first question: what took them so long to do this? It is such an important study. They found that overall children emit particles at a lower volume of adults. Now, we've been talking about this for a long time because we said that, that was when we noticed that children weren't getting COVID at the same rates that adults were, and that was we were speculating. The study also showed that when they shouting between adults is the same, but they found that on average children are less loud than which, depending on which adult that may or may partially accounts for the difference in observed aerosolized particle. Here you have Professor of Virology, microbiologist, said that the results are partially explained by differences in respiratory anatomy. They said children have slightly lower and probably significant viral loads than adults, yet are less susceptible to infection and more to be asymptomatic. Kids on average release fewer respiratory aerosols than do. So here we go. Here's another study, kind of what you and I have been saying for a long time, Eric, that kind of trying to understand the rationale as to why children were getting COVID to the same levels. Where this study is peer-reviewed, all the things that you just said, hard to do, but it seems like it really kind of solidifies the things that you and I have been talking about some time now.
Yeah, so I was about to say, all this actually kind of makes sense based on everything that we anecdotally and observationally have been talking about throughout this process. And again, as time goes on, we'll find out more.
Absolutely. So on to some vaccine news. We're very excited to hear that these are being released. This is great news, especially for resource-poor part of the world. Here's a new vaccine that's strong protection. You probably saw this in the news for a couple of days. So European drug maker Sanofi and GSK announced a positive result of their new vaccine called Vidprevitine. Now, the Vidprevitine uses older COVID technology, uses a protein subunit vaccine, which essentially uses those protein fragments that teach the immune system to spot and fight off SARS-CoV-2. Look at our video at NoiseFilterShow.com. Watch to see how vaccines work. In that animation, what you're going to see is Doc Griggs and I showing how mRNA is used to teach the immune system to stimulate immunity. Here, what is used is an older technology, which is very, very effective, but where they use protein fragments. Essentially, are introduced. Those are called antigen. They're called epitopes, essentially, and those epitopes essentially teach the immune system how what a spike protein essentially looks like. And promising results studies after 2 days, it was 58% of at preventing COVID, at preventing moderate or severe COVID, 100% effective at severe COVID, including hospitalizations. So this is really, really great news. These results are actually a little, and of course we're comparing apples and oranges, but they were still a little bit better than the Pfizer and Moderna numbers. But again, they were tested on different conditions, circulations of virus. Is that this is certainly a tool in our armamentarium and a new vaccine. There's nothing here that talks about pricing on it, but I do hope that the pricing on it is reasonable so that we can see better results with respect to more vaccine equity across the globe. Eric?
Yeah, we heard about all of this at the very beginning, and all of these vaccines were supposed to be, well, not all of them, but a lot of them were supposed to be reasonable. And I don't know how much of that actually materialized. We can only hope, because until we see the world, the globe, as a living, breathing organism, and us being human beings as the parasitic viruses, and understand it until the entire world is vaccinated or protected, we're going to keep having this problem. And that's where we get into vaccine equity and health equity.
Mm-hmm. And something that we've learned, a term that we've been hearing a lot of for the last 2 years, which I think is vaccine apartheid as well. Eric, back to needing to pick your brain about health communications. CDC have released, or they plan on releasing new metrics to guide COVID-19 restrictions. I'm not sure about this. I certainly did it for the show. New metrics to guide COVID-19 restrictions squaring as early as Friday. The CDC currently says that people in counties with substantial or high levels of COVID-19 transmission should wear masks indoors. Now, some of the issue, this is my commentary, that they never really talked about what those high levels are. Now, they will not be changing that guidance, but will be changing the way it assesses community levels of disease. Good. By shifting from case alone to looking at meaningful consequences of hospitalizations, emergency room visits, and deaths. Now, the reason why that's important is because we can't tell, especially with rapid, who is actually getting what are considered cases. But what we can see is with things that we can actually measure, such as mortality, hospitalization, ICU, later use, we actually know what's happening. Right now, 97% of counties are at substantial or high transmission according to the current map, but with these metrics result in fewer counties at the level of transmission. Guidance about mitigation measures such as masking, social distancing will be based on the levels of disease. So essentially, Eric, new guidelines, again, new metrics. Again, as somebody who advises in health communications, and kind of what I've seen the CDC do with respect to guidelines and stuff. What are your thoughts here? What do you take from this?
So I think as we continue to talk about it, as you continue to describe what's going on, these actually make sense. The meaningful changes and recommendations are the measurable ones and the things that can keep society going. The purpose of vaccines and all of our protections is to keep people out of the hospital, and because contrary to popular belief, there's not a hospital bed for every person in our country. It just doesn't work that way. And when the system gets overwhelmed, everything gets backed up. So I think these are meaningful. I think this one is a meaningful guideline change that if you listen long enough, you'll understand how reasonable it is. And then again, it's the evolution of science, which is the evolution of governing policy. And that's how public health is established, right? So I think this is, it's a matter of building trust and telling people why you're changing, why you're evolving, not changing, why you're evolving. And, and so I think this is a good one. I mean, not like I'm evaluating good versus bad, but I think this one can be more palatable as long as you can keep people's attention enough to listen to the explanation.
Yeah, 100% agree. I think that records and changes like this are incredibly important. We've talked about this a number of times, how difficult it is to measure cases. We've talked about how difficult that is. Certainly with death, especially at the beginning of the pandemic, we could who was dying of COVID or not because we couldn't even diagnose COVID at that time. Now I think we're in a much better position. We know that the deaths are far greater than what were initially reported. We'll talk about that in just a little. But these numbers, you can count the number of people that are in the hospital, in the ICU. And so I think these are going to be more meaningful. And I think my only concern is that these are lagging indicators. And so it's not going to be as helpful as test positivity, which I think is a very good indicator. Of course, you want your test positivity to be 100%, or what your infectivity rate is, or what your RT is, which is the amount of infection that's transmitted from one person to the other. But all that, like you said, Eric, I think this is a positive thing. But too little, too late. You think, Ryan?
No, it's not too little, too late, because we're still stuck in the same situation. There's no such thing. There's no such thing as late. I mean, this is science. It's going to happen as it evolves. Now, again, we're filtering out the noise of what we heard before, but as the time goes on, we become better. We become more precise. We become more refined in our explanations and what our observations, and even our clinical trials become more focused, so we can give better recommendations. So it'll be interesting to see how things evolve, because there are a lot of questions. There's a lot of things with those being lagging indicators. Even, and we can talk about that offline another time, but it's still important to know what your caseload is, because of asymptomatic infection, its relationship to long COVID, the fact that someone asymptomatic can spread a case to someone else who might be immune compromised, and they could end up in the hospital. So you're going to count that case, but that case that they caught it from matters.
Excuse me. I have a little tickle in my nose. I'm sorry. Yes, indeed. Thank you, Eric. Yeah, I think that if there's any point to bring up, and the point that I think is the one that you and I talk about quite a bit, is just the necessity of reminding the general that guidelines are going to change, and they're going to change regularly.
Yeah.
And so this way, people are not we're not frustrated about these. They come, and just as a right on cue, should we be concerned about Omicron 2? Here we go. New studies talk about Omicron 2 for being right on the cusp of the things that we. So new study BA2 variant into focus, of course, the BA2 variant, the new Omicron on the heels concerning new lab animal experience, maybe both causing more severe disease than the original. Two new studies are helping show how well humanity is defending against the strain. BA2 is 30% more transmissible than the original Omicron variant, which was already 100% more infectious. Okay, that's cool. Just let me know. Which was 120% more infectious than Delta, which was itself 120% transmissible than Alpha, which was 60% more transmissible than the virus that emerged out of Wuhan. So we do have highly infectious organism, certainly the most infectious organism that we've seen since the pandemic, and I submit that it's probably the most infectious organism that we've seen in history. I've not seen anybody say that, so I say that with a little bit of trepidation. But I've never seen something like measles, which is it's known to have the highest transmission rate. A lot of people are vaccinated, but I still have never seen transmit like that. We have a majority of the population is vaccinated. That being said, it's now causing 1 COVID-19 cases worldwide. COVID-19 cases are dropping off the world. The relative proportion of cases caused by 2 is increasing. So we do know we're seeing it lag from countries around the world. Here you have a director of Center of Virology at Beth Israel saying that I do not think that we mentioned BA2. I'm sorry that we do sound a global alarm, but I do think that we need to pay attention to it to have a growth advantage and have some escape from immunity from and like BA1 from most monoclonal antibody treatments as well. Now new studies are providing real while BA2 may its genetic distant cousin and will lead to greater number of hospitals and deaths. So I think that's the big thing here. We're going to continue to see greater cases. I just don't think that we're going to see the level of severity. It's Delta, thank goodness, and here you can see several show that severity of disease significantly on par with one. Eric, before you go, any of that?
Yeah, my thought is the same thought that I brought up earlier when we were on WBOK, is the fact that people need to understand that this is not linear. This is not a linear evolution. Omicron really warrants the sub-2, Omicron and Omicron B. You could almost think that they warrant another letter, because Omicron is not a direct descendant of Delta. It made its own branch on the COVID family tree. So it'll be interesting to see how this evolves, and the fact that if we're going to move to start only counting lagging indicators, what this could mean overall. The bottom line is, like kind of like the example I gave earlier, in the middle of a chemistry lab experiment, while the experiment is going on, at no point do you take off your goggles or your lab coat or your gloves. You leave it on. So I think we need to be continually respectful of the fact that this is something that has shut down the world. And until we see it all the way through, become more comfortable with the new world that's been created as a consequence of the fact that this and its descendants are going to be with us for the foreseeable future. That make sense?
Yeah, absolutely. 100%. 100%. I think that also this is also portending to is that we are going to start these variants emerge, and we're to be ready for variants like this will be emerging. You thought there?
No, we said that. I mean, that was kind of what I alluded to. If Omicron emerged as its own variant from an earlier version of COVID, an ancestral version that was not in the Delta or Alpha line, then the sub-2B came directly from Omicron. Viruses mutate. That's what they do. And they don't read books. Apparently, I've never met a virus with a college degree or a high school diploma. So we just have to wait and see.
It's never too late.
It's never too late. It's never too late.
You never know when you may see a virus with a college degree. No, but I do think those of us with college degrees and advanced degrees have a lot to learn from viruses.
Absolutely. But if I ever meet Dr. COVID, I'm dropping the class.
Yeah.
With that,
I've been called Dr. COVID. I've been called Dr. COVID before in the past.
Yeah, they never said that to my face, and I hope they never do. I'm gonna have to check out. I'm gonna have to check out. But we'll be back next week, and I'll be back to talk about what's happened since today. Hopefully, I'll be back.
Mardi Gras, you'll have the strength post Mardi Gras.
Yeah, I'm gonna drink a lot of water. No blow dryers up my nose though. No blow dryers up my nose.
Thanks. Last thing we need is a blow dryer on Griggs' nose. All right,
right,
I will be continuing this show on my own. We have a number of more news stories that I'm going to get through before we get through some of the epidemiology. Thank you for joining us, Doc Griggs, today.
Take care. Love y'all. Happy Mardi Gras.
Yep.
Health is a human right. Shut up, take the shot, and put on your mask.
Wash your hands.
Wash your hands. Wash your nasty hands.
All right, let's slide into the COVID. This more likely heart attacks strokes and clotting. We've been talking about this. We said that we have an infectious prothrombogenic. You start an inflammatory response, and as a result of that inflammatory response, you get inflammatory heart disease, but strokes and heart attacks are all clots that could theoretically arisen from an inflammatory response, because again, inflammation is prothrombogenic. When you have an inflammatory response, it could lead to clots, and so this is what we're seeing. Prior infections were more likely to develop a cardiac issue. Many of these conditions, such as embolism, again, a clot, are life-threatening. One thing was sobering was the risk was evident in even people who had mild disease and did not need hospitalizations. So this is significant. This is something to talk about. As disease severity and the risk of cardiovascular complications in the long run, people who had been treated in ICU had the highest risk of cardiovascular disease after recovery. For example, people who weren't hospitalized were twice as likely to have coronary embolism than people who had not had COVID-19, and those treated in the ICU were 21 times more likely to have one. This was found across all ages and cardiac risk factors such as smoking and high blood pressure and obesity. People with COVID-19 infections were more than 5 times myocarditis. We've talked about myocarditis. We do know, of course, vaccination status does that. Now, although the robust sample size, most of the people are white men, and because the study enrollment period ended January 15, 2021, vaccinations were widely, 4 vaccinations were widely available. None of the participants needed. So certainly a question that we need to see is what the likelihood was of vaccination here. So we have here, and let me see if there's anything more to cull from this. As I have here is that is not surprising anybody, let alone me, and what we've been talking about on NoiseFilter since the get-go, and that is that what we have and what we fear, and something that we are constantly what we oh no really you guys can't at all up. Oh, I am so sorry. Hang on, check to make sure audio and everything is fine. It appears my audio fine. I'm not sure. I think it may be. I'm wondering. It looks like my internet. It looks like just my network connection is just really poor, and I am sorry about that. I'm sorry that the quality is really bad as well. I did spend some time prepping this show. So hello to all of you guys that are saying hello. Hello to Miss Margaret up in Canada. Thank you for watching. Yes, I will. You know, we're supposed to have great internet. I always tease Dr. Griggs for having horrible internet status, but we're supposed to have, like, I ordered the best possible package here. Anyway, that being said, it's certainly important. And I think that it's something for us to recognize. For all of your friends that are like, COVID is no big deal or whatever, I have always been taught how important it is that we recognize what some of the effects of long COVID. And here we go. This is a great example of how long COVID does affect coronary disease, but more importantly, more than coronary disease, it's cardiovascular disease, just heart clots. It's also more importantly, all the different parts of the heart works. So it's the plumbing element of the heart, it's the pumping element of the heart, and of course you can get clots as well. So it is important for us to recognize that people who are super nonchalant about COVID, we do need to recognize that these long-term effects are there. We're starting to document them, and I really wish that people will recognize how important it is that we are aware of these long-term effects. All right, I think that this is a paper to read. I am going to go through it. I think that it is important. It's our nursing workforce will crawl if not made. Ask any nurse. There are more than 4 million of us. How your answer will be the same. Nurses are not. After nearly 2 years, the COVID-19 pandemic has upended us. I know firsthand. I'm a family nurse practitioner as well as a researcher over the past 2 years. This Omicron cases, I've been stretched to our limits. I see patients of all ages, walks of life, many of whom don't have a primary healthcare provider. I help them manage multiple COVID testing, vaccination treatments. In addition to filling in those gaps in primary care, right now there's no quick healthcare visits. There aren't enough nurses to take care of the need. It has been heartbreaking to wait because of the lack of available appointments. But for many, the patients I treat, the reality of the pandemic today may feel better in 2020. We have vaccines and boosters, better plans, and much more supply of masks and other PPE. Much like the public, for better or worse, has found equilibrium of life while trying to mitigate the risk of contagion. Inside the hospitals and clinics where I work, however, the reality is much different. 2022 can feel far grimmer than we experienced with the start of the pandemic. 100%. We have vaccines and more PPE now, but yes, frontline waves of infection has carried an extreme and emotional burden, leading to immense burnout. Man, I agree with that. Times I request to pick up additional overtime shifts or volunteer my time at a local hospital when other nurses have been out. When I get these requests, I feel trepidation far worse than the day in April 2020, the alert popped on my phone saying, all attention healthcare workers, New York City seeking licensed healthcare workers to support health. I get requests all the time, and boy, I do it. It has been very, very taxing. It's more than the labor of taking care of a great number of patients. It is the hopelessness that comes from seeing the sight and meeting people who won't face the truth. Our vocal fellow Americans who still deny the pandemic real threat, that SARS-CoV causes COVID-19, that it's airborne, that people can die from it for long-term complications. The rejection of reality feels like a betrayal. While my colleagues and I are doing everything we can to prevent patients, despite exhaustion, there are still patients filling up waiting rooms who have not gotten vaccinated or taking preventative measures such as wearing masks to protect themselves. And while some of the public may choose to be pandemic, obviously care workers, this is not the case. So I do get requests to pick up hours. I'm faced with a dilemma, take on work at a considerable exhaustion. Many times I choose to take the work, as do I. Burnout is real, guys, and I do think that it is important for us to recognize that in healthcare that we are starting to see significant amounts of happening. And until we address what is happening, we will see continued burnout. And as I have said, things that I've been particularly concerned about is what has with our healthcare system. I've made this multiple times that I am super concerned of what is happening with colleagues. While I am in and out of the hospital, I come and go from a hospital. I am not in the hospital every single day. Every time I go back, they just seem a little bit more tired. They just seem a little bit more exhausted. They seem a little bit more weary. And so I just want to touch the healthcare workers, unfortunately, who have burnt out. I think the last time we were on air, we highlighted a healthcare worker, an old colleague of mine, who did healthcare sector and entered tech. She was an incredibly talented control nurse. She went into employee health nurse system, and it was really sad to hear her go. But I understand why they're going. Before we shift over to G and start to kind of round the corner for this week's show, I have a few minutes talking about Dr. Paul, who's a personal hero of mine, personal hero, I'm sure, of many hundreds of thousands of people. And it is not with hyperbole that I say he's quite frankly and quintessentially saved millions of people. So this obituary from the New York Times: as a medical student, Paul sorry, I get choked up. I met Paul Farmer once. I'll tell you that story in a moment. Paul Farmer, pioneer health, dies at 62. As a medical student, Dr. Farmer decided to build a clinic in Haiti, then grew into a vast network in some of the world's poorest communities. And let's just review Dr. Life. I do have several connections to Dr. Farmer I'm going to review. He's a physician, anthropologist, and humanitarian, global acclaim for his delivering high-quality health care to the poorest people. He died on Monday on the Gras Hospital and University that he established in Rwanda. He was 60. The cause was an acute cardiac event, according to a statement by Partners in Health, the global public health organization that Dr. Farmer helped. My understanding from my brother-in-law, who did do the documentary of Dr. Farmer, you can find that on Netflix, called Bending. My brother-in-law, David Bell, did comment to me that his father, Dr. Farmer's father, also died at a young age of a coronary. Dr. Farmer attracted renown with Mountains Beyond Mountains, the quest of Dr. a man who could cure the world. In 2003 by Tracy Kidder, the extraordinary efforts he would make to care for patients walking out to ensure they were taking their medications. He was a pioneer of social medicine, arguing there was no point in treating diseases, only to send them back to desperate circumstances that control them in the first place. Illness, he said, has social roots and must be addressed through social structures. His work in partner health significantly influenced public strategies for responding to TB, HIV. During the HIV/AIDS crisis in Haiti, he went door to door to deliver antiviral medications, confounding many in the medical field who believed it would be impossible for rural people to survive the disease. He worked in global development. He often took a critical view of international aid, preferring to work with local leaders. And he often lived among the people he was treating, moving his family to Rwanda and Haiti for extended periods of time. News of Dr. Farmer's death rippled through the world of medicine health on Monday. There are so many people that are alive because of this man, said Michelle Walensky, who is the director of the CDC. This time, you guys probably heard about this, but Dr. Fauci broke down in tears during an interview in which he and Dr. Farmer had been, and said that he and Dr. Farmer had been like soul brothers. When you talk about giants in the field of health, he stands pretty much as a very short list of people. Dr. Fauci, Dr. Farmer decades ago, when Dr. Farmer was a medical student, he said he called me his mentor, but in reality, he was more of a, in the latter part of his career, Dr. Farmer, public health luminary, the 27th documentary, Ben the Ark, and the author of 12 books. Again, you can see the Ark on Netflix. So it was directed by my brother-in-law. In 2020, he was awarded the $1 million Bergeron Prize, given annually to an influential thought. The chairman of the prize committee, Farmer, had reshaped our understanding of what it means to treat health as a human right and the ethical and political obligations that follow. So we want to just acknowledge Dr. Farmer's passing and what an incredible influence he's been on a number of people, myself included. I did with Dr. Farmer once after doing some Haiti, and was at the Port-au-Prince airport leaving Haiti when I saw Dr. Farmer and sat down. He was having a drink. I sat down with him and we had a drink together. And it was great. He was incredibly generous. We spoke for about 15 minutes, talked about HIV, and I was just starting WHIV. We talked a bit about WHIV, New Orleans' only community radio station dedicated to human rights and social justice. Probably really the U.S.'s station dedicated to human rights and social justice. After the conversation, he actually gave me his phone number. He handed me, like, this is my personal information. Stay in touch with me. And I didn't. And I regret that I didn't. I wish I did. I was somewhat intimidated and a little unsure of myself, and of course, when we meet somebody, Dr. Farmer's Calla, it's easy to doubt yourself, and certainly I doubted myself, and I having done that, it occurred to me that it was that I could still reach out to him at that point. Water under the bridge. Should have reached out to him a week or two later. But this is from the amazing career that Dr. Farmer had. He saved millions of people's lives, and he's influenced hundreds of thousands of people like myself, and really gave rise to a nascent, emerging specialty in medicine health. As you know, this radio program is called Right, and this is something we're said all the time. So with that, let us round the show, wrap this up with going into some of the epidemiology of where things are at. Global epidemiology, we are rapidly approaching 430 million cases. Deaths are rapidly approaching 6 million globally. Last added 1,063,944, which is an unbelievable number of cases with 9,000 deaths. And here you can see in this graph, while cases are going down significantly, we are still in the high 1 million globally. And certainly we see with deaths, we are still not at 10,000 deaths anymore. Globally, we're still just below it. So while it feels like we're done with the virus, you still see cases are still intense globally. Looking at cases by region, we see that the two areas that had the highest amount of cases, which of course was Latin America and Canada, so I'll just refer to them as those have gone down significant. Heat map here, you can see Canada's cases and Mexico's case significantly. Still number of cases in the U.S. and Brazil, but the rest of the South America, minus Chile and another country or two, are still struggling, but for the most part, it definitely looks like things are getting better. And while things are a little bit better in Eastern Europe, we are seeing some still number of cases throughout all of Northern Europe, all the way extending into what I just learned is 11 time zones in Russia. Russia has 11 time zones, as you can see, what a massive landmass that. In the U.S., we're at 80,334,122 cases. Deaths are 965,890. So rapidly approaching a million deaths. Number of cases were 64,808. Yesterday, with number of deaths of just north of 16,000. So we're seeing a number of cases, and even though this map, which peaked out at 800,000 cases, we are still seeing a number of cases. Cases are declining significantly in the U.S. Cases, hospitalizations are declining as well. So I think that we are appearing to be in a good. This is the best place that we've been in a long time, and so this is very positive, and I'll take it. This is super important. When we look at cases per region, we see the entire country cases are coming down significantly. Look at a heat map of the U.S., you can see that still some pockets of cases, especially in the Midwest and somewhere what appears to be the South/Midwest/ Kentucky, Illinois. But hopefully cases will chill out. My former state of Maine appears to be a hotspot right now, as does Alaska. So when we look at the rates of vaccinated versus unvaccinated average daily cases, from cases dated January 16th to the 22nd, the unvaccinated were as 3 high as those that were fully vaccinated. So again, the vaccinated counted times the average daily cases. At average daily deaths, you can see the daily deaths unvaccinated counted as 10 times as high as those that were fully vaccinated. Average daily deaths were 10 times as high as those that were fully vaccinated. I know I showed this graph last time. I wanted to show it again because I think that if the U.S. had the same breadth and depth of vaccination as Denmark, hospitalizations have as a result of this recent wave of COVID-19. Looking at Louisiana directly, we're at 224,028 cases. Number of deaths are 16,557. Last night we had almost 1,600 new cases, 53 deaths. So in Louisiana, it may seem like we don't have a lot, but we are still seeing cases and we are still seeing deaths. So please, yes, this looks like that we don't have very many cases, and I understand that, but also remember that we have a different scale, right? This number as at the beginning of the COVID epidemic, when we were all still in lockdown. So that scale fool you. We still have quite a number of cases, but that being said, hospitalizations continue to decline, deaths are declining as well. This is all good news. Are recommended indoors by state officials, and school mask policies are up to local discretion. Heat map, you can see here Iberville Parish, and what parish is this? I knew that a second ago. I can't remember, but the Iberville Parish is still the highest. You can see the rest of eastern Louisiana is pretty chill. When we look at new cases compared to last week, it's come down almost by half. The infection rate has come down significantly, and test positivity. So I think in terms of Atlanta, and specifically when we look at Orleans, daily cases have come down by over a half. Infection rate, notably, test positivity has come down. Our vaccination is 80% with one dose or more, significant as well. So when we look at where we're at, I think we are in a good place, both globally. Still not out of it, but certainly here in the U.S. and certainly here in the state of Louisiana, I think we are doing. I think that we could be doing better, but I think for that matter, we are in a good position. And I think, to be honest with you, we're going to be probably chilling like that. We'll do this show for weeks to come until some new peak happens, some new variant happens. But we'll probably just be reviewing data, and it's not going to be as hot as it was last year, which is a good thing. Which is a good thing when we started this show, where we were always doing news. But I think we are going to start to see COVID in a bit of a mirror. We are going to see we are going to see continued cases, but it's going to be a lot lower. Remember, Mother Nature did a favor by introducing Omicron, because what essentially Omicron did was it found all of those that were unfit and at least gave them some level of, and with that level of immunity, I think we're going to see declining hospitalizations, mortality as well. With that, I hope everybody has a great Mardi Gras. Please wear your mask, only indoors as the mask mandate calls for, but please also wear your mask outdoors, especially if you're in groups of people watching parades and the likes. Thank you guys so much for tuning in. Thank you enough. I do appreciate it. Your support for the show has been tremendous, and please share this stream and let people know that we are once the show posts what we're doing. You guys, health is a human right. Get checked, get fit, get moving. Everybody have a great Mardi Gras. Guys, we can't do this without you. Thank you. You have been listening to 102.3 WHIV.